In this 10-minute video podcast, I'll be giving an overview of Addison's disease and primary adrenal insufficiency. I'll aim to cover the normal hypothalamic pituitary adrenal axis, the pathophysiology behind primary adrenal insufficiency, how the pathophysiology manifests in clinical signs and symptoms, and its management. This will be followed by a quiz designed to assess your learning from the podcast and highlight any areas that you need to revisit with self-directed learning. The normal hypothalamic pituitary adrenal axis. There are two adrenal glands which sit superiorly to the kidneys. Their function is to produce hormones. They consist of an outer cortex and inner medulla. The medulla produces the catecholamines, epinephrine, norepinephrine, and dopamine in response to sympathetic nervous system input. The cortex is further divided into three layers, remembered with the mnemonic GFR: glomerulosa, fasciculata, and reticularis. Their respective hormones can be remembered with the mnemonic My Giddy Aunt: mineralocorticoids, aldosterone, glucocorticoids, cortisol, and androgens, DHEA. All three cortex hormones are steroid hormones which derive from cholesterol. After cholesterol has been converted into pregnenolone, the production cascade splits into two pathways. Firstly, progesterone is the precursor to both aldosterone and cortisol. Several steps are involved in the conversion, but both aldosterone and cortisol production require the action of enzyme 21-hydroxylase. Through the alternative pathway, pregnenolone is converted into DHEA through several steps. Aldosterone is released in response to angiotensin II production to increase mean arterial pressure. It does this by upregulating the sodium-potassium pump within the distal convoluted tubule of the kidney. This results in sodium and thus water being pumped into the interstitium and potassium being pumped out into the urine. Cortisol is released in response to stress and has several effects. It increases blood glucose through stimulating hepatic gluconeogenesis and facilitates epinephrine's induction of hepatic and muscle glycogenolysis, the breakdown of glycogen to glucose. Cortisol also causes immunosuppression through downregulating interleukin-2 receptors on T helper cells. DHEA is a precursor to both testosterone and estradiol. On top of their individual inducers of hormone production, all three of the cortex hormones are produced in response to adrenocorticotropic hormone, ACTH. ACTH is produced by the anterior pituitary gland. Its production is in turn stimulated by corticotrophin-releasing hormone, CRH, produced by the hypothalamus. The hypothalamic pituitary axis is regulated by negative feedback at every level. Therefore, if a cortex hormone is in high concentrations, it will negatively feed back to the pituitary and hypothalamus, decreasing production of ACTH and CRH respectively. Likewise, if ACTH is high, this will result in hypothalamic suppression of CRH. This concept will be revisited later as we can use it to localize a problem within the axis. We will now move on to the pathophysiology behind primary adrenal failure. Addison's disease is an autoimmune deficiency in both aldosterone and cortisol, but not DHEA. It's a form of primary adrenal insufficiency. In the hypothalamic pituitary axis, primary refers to problems within the adrenal gland, secondary to the anterior pituitary, and tertiary to the hypothalamus. The causes of primary adrenal failure can be split into adrenal destruction, adrenal dysgenesis, which is genetic, and problems in steroid production and corticosteroid withdrawal. Adrenal destruction is the most common cause of primary adrenal failure in the UK and occurs due to autoimmune adrenalitis. Autoantibodies are directed against the enzymes within the common aldosterone-cortisol steroidogenesis pathway, such as 21-hydroxylase. Because DHEA does not share the same pathway, its manufacture isn't affected. Problems in steroid production can occur because of cholesterol deficiency. Most commonly, however, they are due to congenital adrenal hyperplasia. This is where the individual lacks an enzyme required in the aldosterone-cortisol common pathway, such as 21-hydroxylase. In corticosteroid withdrawal, exogenous corticosteroid use suppresses levels of CRH and ACTH through the hypothalamic negative feedback loop. This causes adrenal atrophy and steroid deficiency. Adrenal dysgenesis is caused by genetic conditions which prevent growth of the adrenal glands, such as congenital adrenal hypoplasia. Low levels of aldosterone and cortisol lead to an increase in ACTH as the negative feedback loop does not take place. Effectively, the anterior pituitary is trying to stimulate cortisol and aldosterone production. In congenital adrenal hyperplasia, this ACTH excess causes adrenal hyperplasia. I'll now cover some symptoms and signs of Addison's, which don't occur until 90% of the adrenal gland has been destroyed. Hyperpigmentation. In primary adrenal insufficiency, hyperpigmentation occurs in non-sun-exposed areas, such as the buccal mucosa and palms. This is due to elevated levels of ACTH. ACTH and melanocyte-stimulating hormone have the same precursor molecule. After production, ACTH is further cleaved to produce alpha melanocyte-stimulating hormone, which stimulates melanocytes to produce melanin, colouring the skin. Hyponatremia, low blood pressure and salt craving. Deficiency in aldosterone means that the sodium-potassium pump in the distal convoluted tubule doesn't work. This leads to a decreased sodium and water resorption from the interstitium and thus blood, and urinary loss of sodium. Hyperkalemia. Likewise, this occurs because of the lack of aldosterone, which would normally pump potassium out into the urine. Hypoglycemia. This is because of a lack of cortisol, which normally stimulates gluconeogenesis and glycogenolysis to increase blood glucose. Diagnosis. Diagnosis is carried out with a synacthin ACTH stimulation test. Synacthin is an ACTH analogue. In the short test, baseline blood cortisol levels are measured, which should be above 170 nanomoles per litre, followed by 250 micrograms of synacthin. 30 minutes later, cortisol is measured again, and in normal individuals, this should rise to over 580 nanomoles per litre. Treatment. Treatment is through supplementation of cortisol by hydrocortisone and aldosterone by fludrocortisone. We'll now do a quick quiz to recap what we've learned. This patient's problems lie in the anterior pituitary gland. We can see this because the hormone which the anterior pituitary gland normally produces, ACTH, is low. Therefore, cortisol is also low. Aldosterone is normal, however, due to the still functioning renin-aldosterone system. CRH is high because low levels of ACTH and adrenal hormones are negatively feeding back to the hypothalamus. Congenital adrenal hyperplasia is most commonly caused by a 21-hydroxylase deficiency, and therefore hormones which require this enzyme for their synthesis, aldosterone and cortisol, will be affected. DHEA, epinephrine, norepinephrine, and dopamine production are not affected. Aldosterone acts in the distal convoluted tubule of the kidney to upregulate the sodium-potassium pump. This causes potassium to be pumped out of the tubule and thus urine, and sodium and thus water to be pumped into the interstitium and therefore the blood, increasing blood volume and mean arterial pressure. GFR stands for the segments of the adrenal cortex, glomerulosa, fasciculata and reticularis. Mygidiant stands for their respective hormones, mineralocorticoids, aldosterone, glucocorticoids, cortisol, and androgens, DHEA. False. Patients may present with hyperpigmentation, particularly in non-sun exposed areas, such as the buccal mucosa and palms of hands. This is because the increased levels of ACTH, which can be cleaved to produce alpha melanocyte-stimulating hormone, induce melanocytes to produce melanin, pigmenting the skin. Patients may also be more likely to have concurrent autoimmune diseases, such as vitiligo, which would cause hypopigmentation. That concludes the podcast. So if you'd like to go back to your brainstorm and add anything that you've learnt in, that means that you can review it and then target your STL to cover anything that we haven't covered today or that you'd like to look into further. Thanks very much.